Hi, good morning, everyone. We will start in another minute or so, the live discussion. Hi, so good morning, everyone. Welcome to the discussion on INICET. Yesterday's INICET, we will be discussing the OBG questions, and we will discuss briefly about them. So I am Dr. Reena Chawla, and I am an obstetrician gynecologist. Just a second. Okay, so as I was saying, I am Dr. Reena Chawla, and I am an obstetrician gynecologist with several years of experience, and I have a very keen interest in the field of medical education. And so I decided to make a video uh, 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 regarding the solutions and discussions for yesterday's INICET paper. Now, just before we go to the actual OBG questions, there is, I just thought I'd let you know what my analysis of the paper was. So the good thing for me especially was there was lots and lots of OBG questions. This is very unlike the last year's paper where there were hardly 7 to 8 questions. But this time we had plenty. In fact, 29 questions out of 200 were from OBG. So it's not a subject that can be neglected. It's a very, very important subject. Of course, apart from the OBG part, there was the usual. There were a lot of image-based questions. 40 plus questions were image-based. And as usual, like the previous INICET, there were lots and lots of match the following, multiple answer scenarios, clinical scenarios, which were, especially in surgery, there were lots of clinical scenarios. And these do take up a little bit of time, but overall, I don't think time was that much of a constraint for most. As I said, multiple correct options were there, which also take up a little bit of time. And as expected, there were questions on COVID and also mucormycosis. So all in all, it was relatively moderately okay paper. It was not a very tough paper. And especially the OBG questions were relatively simple. There were some tricky ones also, and we will discuss those in detail. So now let's discuss the questions. 29 questions. I will be very brief. We'll discuss the answers and we will discuss touch on very briefly about each question, a brief description, a brief solution I will try to give you. If you have any doubts whatsoever, you can please leave a message in the chat box and I will get back to you. So let's start. The first question was, out of the below given investigations, which would be preferred for diagnosing a unicornuate uterus? And the options given were a hysterosalpingography, an X-ray, a laparoscopy, and a falloposcopy. And it was a multiple answer question. The options were either the combinations of two of the investigations. So the answer for this was yes, hysterosalpingography and a laparoscopy. Now, please remember when it comes to Mullerian anomalies, and you can see the middle one is the unicornuate uterus. So this could be with a horn or without a horn, irrespective. Most Mullerian anomalies can be diagnosed mainly by 4 investigations, and these are very important to remember. So 3D ultrasound is the investigation of choice for a Mullerian anomaly. MRI also is very, very useful. So both these are non-invasive, a 3D ultrasound and an MRI. Invasive investigations are an HSG or a hysterosalpingography and a hysteroscopy laparoscopy. So if we go back to the question, the choices that were given to us were HSG and laparoscopy, which are correct, and X-ray will have no use. And a falloposcopy is basically introducing a scope into the fallopian tube, which again is very rarely done and is of no use in Mullerian anomalies. So this is how a unicornuate uterus will look like on a 3D ultrasound. This is how it will look like on an HSG, and this is how it looks like. You can see only one horn is formed, the other fallopian tube is missing entirely. So this is how it will look on a laparoscopy. So this is unicornuate uterus. Please remember, Mullerian anomalies diagnosis comes pretty frequently. Okay, next question. HCG is structurally and functionally similar to, is it FSH, is it ACTH, is it LH, or is it oxytocin? And the answer is LH. This was pretty similar. Please remember, HCG questions do come because it's a very important part of obstetrics. So what is HCG? It is a glycoprotein. It has both alpha and beta subunits. The alpha subunit is biochemically similar to LH, FSH, and TSH, but the beta subunit is the unique one. Functionally, HCG is very, very similar to LH. So the correct answer in this case is LH. HCG is similar to LH, in both structure and in function. Okay, so third question. Third question was also relatively easy, especially if you've done your attended cesarean sections, it becomes even easier. For those of you who have not or didn't know the answer, I'll try to explain it briefly. The question was, enlist the instruments you will use in a cesarean section. And the options given were Doyen's retractor, a BP knife and handle, Shirotka's clamp, Karman's cannula, Cusco's speculum, green armitage forceps, and an Alice forceps. And again, it was a multiple answer question. You were given multiple choices. So what is the correct answer? The answer was Doyen's, a BP knife and handle, a green armitage, and an Alice forceps. We don't use a Shirotka's clamp. That is basically a uterine clamp. We don't use a Karman's cannula, which is basically used for suction evacuation. And we don't use a Cusco's. A Cusco's, you all know, is used for examining the cervix, which is commonly used in the OPT. So what we do use is the instruments I mentioned, and I will quickly, just in 2 minutes tell you the steps of a cesarean section. So what do we do first? We cut. What do we cut? The skin and the rectus sheath, the skin, the subcutaneous tissue, then the rectus sheath. And what do we use? What do we use for this? We use the Bard Parker handle and the blade. That's how it looks like, a BP handle. Then we hold the tough tissues like the rectus sheath. So once you cut the rectus sheath, you have to hold it because you have to separate the underlying muscle. So what do we hold it with? We hold it with an Alice forceps. And that's how an Alice forceps looks like. It's a traumatic forceps. It has sharp teeth at the end, triangular. And this is how it looks like. Then what do we do? Once we separate the rectus muscle from the rectus sheath, we separate the two bellies of the rectus, and then we find the parietal peritoneum. We open the parietal peritoneum. Then what do we see? We see the uterus. When we see the uterus, we have to identify the lower segment because we're doing a lower segment cesarean section. So we identify the UV fold of peritoneum. What is the UV fold? The utrovesical fold. Because how do we know that's the lower segment? The bladder is covering the anterior part of the lower segment. So we have to separate the bladder. So to do this, we need a bit of retraction. So we put in a Doynes. See, that's a Doynes retractor. It has a nicely curved sort of an atraumatic sort of end, and that is inserted into the lower part of the uterus. Then we lift the UV fold, we open the fold, and once we open the fold, we are able to push the bladder away, and we advance the Doyne so that the bladder remains away from the field of surgery. Because if the bladder is persistently there or keeps coming in the way, we can end up injuring the bladder. So Doyne's retractor, the purpose is to keep the bladder away. Then we give the lower segment uterine incision, we deliver the baby, we deliver the placenta, and then what we have to do, we have to now start closing. Whatever we open, we have to close. So we hold the edges of the uterine incision with an Alice or a green Armitage forceps. I mentioned before, an Alice is traumatic, but a green Armitage, you can see it also has a wide surface area. It is much more triangular than an Alice, but it is atraumatic also. So if you have especially bleeding edges, then a green Armitage forceps is a better one to use. And of course, then the remaining steps of closure. But I just put this up to show you these four instruments which were asked are very specific, especially the Doynes and the green Armitage are very specific for cesarean section. I will soon put up a video of cesarean section also for a better understanding. But as of now, since we're keeping it very brief, this is the answer. So PP handle, Alice forceps, a Doynes, and a green Armitage are what is used in a cesarean section. Next question. The uterocervical length in an adult woman, very simple. The answer is 7 centimeters. Okay, so all of you should know this. Anatomy, the length of the uterus is about 7.5, width is 5, and around 2.5 centimeter thickness. Basic anatomy, this could be from an anatomy this side, this could have been from OB side, but very simple question, straightforward answer. Okay. Next question. So next we have 3 questions on pap smear. So pap smear is very, very important. Okay. In fact, oncology as such, gynae oncology is important. I would have actually said contraception is also important, but nothing came from contraception. So that's how the exam is. You get so many, we got 29 questions, but the distribution was sort of skewed. So everything is important. And as you can see, pap smear, 3 questions. So those who have read this would have got 3 right instantly, right? So it's very important to be very thorough with what you're reading. So what is the order a pap smear is taken? This is the first question. So again, multiple, this was sort of a put in the order of multiple answer questions. So what is the first thing you will do? Yes, you will insert a vaginal wall retractor. Then what will you do? You will scrape the ectocervix, then prepare the smear, then fix the slide. So this was very, very simple. I think even if you've not read, you can just figure it out what needs to be done. We'll do the discussion after all the three questions. So the second question was on pap smear was identify. So this was approximately such a diagram was given. Apart from the cusco speculum, the iris spatula, the cytobrush, and the slide, there was also a picture of a Koplik's jar. Koplik's jar is where the fixative is, where we put the slide in. That was additionally there apart from these instruments. And it was asking what is the procedure done using these instruments. This is very obvious when you see the air spatula and the cytobrush, it's very obvious that this is a pap smear. And the third question that was asked, what is the fixative used for pap smear? And the answer is 95% ethyl alcohol. So this is a pap smear. This is how it's done. You first, there are certain prerequisites, which I won't go into. What age is it done? Till what age is it done? How often it's done? The woman should not have had intercourse 48 hours before, no vaginal douching 48 hours before, no bleeding. She should not be on her period or she should not have any bleeding when you're doing the pap smear. Apart from that, once the prerequisites are fulfilled, we introduce the cusco speculum. We use a cyto brush for the endocervical sample, and then we use the wooden eye spatula for scraping the transformation zone on the ectocervix, rotated by 360 degrees. Then fix this, smear the cells on the slide and fix it with 1:1 mixture of 95% ethanol and ether. You can either fix it, you get fixative sprays, or you can put it, dip it into this fixative in a Coplex jar. Either way, this is the procedure for a pap smear. Okay, so pap smear, very, very important. You can see 3 questions from here directly. So it's very easy questions actually. So if you've given it one reading also, I'm sure most of you have been able to answer these 3 questions correctly. Next question. There was a group of symptoms given. What are those symptoms? Dysmenorrhea, infertility, irregular menstruation, and vaginal discharge. And which of these are seen in endometriosis? Again, a combination. So combination of 2 symptoms were given. Now, many of you, I think, have got confused in this question, but the answer is A and B. Please remember, endometriosis, classically 2 symptoms, pain and infertility. Pain and infertility is what is most common. I agree, irregular menstruation can be there, but more than irregular menstruation is actually menorrhagia. What is menorrhagia? Regular cycles, but with heavy bleeding. That is the characteristic abnormal uterine bleeding that we find. Instead of irregular, it is actually regular, but heavy cycles. So if we had HMB or menorrhagia, what is HMB? Heavy menstrual bleeding, or menorrhagia, that would have been maybe a better answer. But dysmenorrhea, infertility are definitely the most common symptoms. And how do we remember this? I always teach my students 5 Ds of endometriosis. What are the 5 Ds of endometriosis? Dysmenorrhea, dysfertility. Okay, dysfertility basically means infertility, but to make it a D, we made it as dysfertility. Dull aching abdominal pain, dysgesia, and dyspareunia. So these are the 5 Ds of endometriosis. All right. Important, so don't get confused. Pain and infertility are the most common symptoms. All right. In fact, most standard books don't even mention AUP. Novak's, which is our standard book, just mentions dysmenorrhea and infertility. So these are the 2 most common symptoms. Next question. A 24-year-old woman is being evaluated for amenorrhea. You order a hormonal profile, which is the correct match. Okay, so again, I think we had 3 match the followings in this paper. So match the followings are now becoming a favorite for the INICET in all subjects, in fact, and they're actually pretty fun to do. Okay, and they're easy to do also, because if you get 1 or 2 options, you can easily guess the rest. All right. So the options, the disorders that were given were premature ovarian failure, Asherman syndrome, PCOS, and Sheehan syndrome. And what were the options? Basically 3 hormones were given: FSH, LH, and estradiol. Okay, so what was the correct answer? This was the correct answer. So premature ovarian failure, please remember, is basically hypergonadotrophic hypogonadism. What happens in menopause? It is like menopause. What happens? The ovaries stop functioning. Hence, there is a negative feedback, and FSH, LH increase, but since there are no follicles, the estradiol remains low, similar to what happens in menopause. FSH is high, LH is high, estradiol is low. What happens in Asherman syndrome? What is Asherman syndrome? It is nothing but uterine, intrauterine synechia or intrauterine adhesions. So basically, the defect is at the level of the uterus, right? So everything else is normal, but she's not bleeding. She has amenorrhea because of problems inside the uterus. So the ovaries are functioning fine, the hypothalamic pituitary axis is functioning fine, and hence everything will be normal. FSH is normal, LH is normal, estradiol is normal. What happens in PCOS? There is a change in the FSH-LH ratio. LH becomes high. It may be within normal limits, but it is higher than the FSH. Estradiol remains normal. So for PCOS, we have a high LH. Remember, high LH is seen in PCOS. Sheehan syndrome. What is Sheehan syndrome? It is basically pituitary failure because of second postpartum hemorrhage is usually the precipitating factor. So that leads to decreased blood supply to the pituitary and pituitary failure. So what is that? Hypogonadotrophic hypogonadism. So the pituitary is not functioning. There is no FSH-LH being released, and hence the estradiol levels are low. So Sheehan syndrome is hypogonadotrophic hypogonadism, and hence FSH-LH low, estradiol low. So this was the correct matching for this question. There was one more match the following. I put it together with this. So match the correct condition with the karyotype. So again, we had 4 different syndromes. Mayer-Rokitansky, Kuster-Hauser syndrome, Swyer syndrome, Turner syndrome, and AIS. This was also very simple because two of them have 46XY. So it became very, very simple. And we all know Turner's is 45XO. So it becomes simple. MRKH, please remember, is basically uterine agenesis. She has ovaries. The girl will have ovaries. She is 46XX. Swyer and AIS both are the genotype is male. All right, so it is 46XY, but they have female phenotype, right? So Swyer, AIS are 46XY. Turner's we all know is 45XO. And this also was a relatively simple question simply because two of them are 46XY. So it became very, very easy to do. So this is another match the following question. And these, so amenorrhea is a very, very important topic. Many of you get frightened by it. It seems very intimidating, but it's actually a very simple topic. And if you sit down, give yourself a few hours and sit down and understand the topic, it becomes very, very simple. A lot of questions on amenorrhea, which was again expected. So don't skip amenorrhea. It's a very important, very scoring topic. Okay, so this is a question which you can put in surgery also, but so it's common to both surgery and gynae. Identify the instrument used to insufflate the peritoneal cavity. This is a Verres needle. Okay, this is a picture of a Verres needle. So what do we do in laparoscopic surgeries? We basically laparoscopic surgery involves insufflation of a gas, usually carbon dioxide, into the peritoneal cavity, producing what is called a pneumoperitoneum. So that once the peritoneum is full of carbon dioxide, it makes it easy to operate. And so the first step in laparoscopic surgery is creating a pneumoperitoneum. And this is done using a Verres needle. That's the picture of a Verres needle being introduced subumbilically. There are many other questions which are asked on this, but I won't go into details. Remember, in a thin patient, it is introduced at an angle of 45 degrees. Then how do we know it's in the correct position? All that is a separate topic. But this comes under both surgery and gynae, very, very important because laparoscopic surgeries are the norm these days. Everything is done laparoscopically. So this is one more topic which cannot be ignored anymore. You need to know laparoscopic surgery details. Okay, next question. A 15-year-old girl presents to the OPD with amenorrhea. Her breast and genital exam are normal. She is found to have 5-alpha reductase deficiency. So what is your diagnosis? Is it a male pseudo-hermaphrodite? Is it a female pseudo-hermaphrodite? Is it true hermaphroditism or is it concealed sex? Okay, the answer is male pseudo-hermaphroditism. This is again a topic which most of you skip. Okay, I understand it's a little difficult, but it is important. It may not be important from a university point of view, but very important from MCQ point of view. So for those of you who are interested, this is a very nice book. It's a Pulitzer Prize winning book by Jeffrey Eugenides, Middlesex. It's about a girl who has 5-alpha reductase deficiency and who is basically diagnosed later on in life, and then the trauma that she undergoes realizing her sex. So what is male pseudo-hermaphroditism? It is basically 46XY. So remember, when we say male and when we say female, the male and female refer to the karyotype. Okay, so male pseudo-hermaphroditism is a 46XY individual, but who exhibit varying degrees of feminization, and a very common cause, rare, but amongst the rare, the common cause is 5-alpha reductase deficiency, which is an autosomal recessive condition where there's an inability to convert testosterone to dihydrotestosterone because of the deficiency of 5-alpha reductase, okay, which is required for masculinization of the external genitalia. So they have testes, but they do not, their external genitalia is of a woman. They have female phenotype, but they have a male karyotype. Similarly, female pseudo-hermaphroditism is masculinization of the external genitalia in a patient with a female karyotype from exposure to abnormally elevated levels of androgens. And one of the common causes of female pseudo-hermaphroditism is congenital adrenal hyperplasia. What is true hermaphroditism is when they have an ovotestis. It is very, very rare. Okay. But what happens in this? It is due to chromosomal abnormalities and or abnormal cleavage of the X or Y chromosome. But what happens? You'll find both ovarian and testicular tissue when you examine the gonads under histopathology, you will find both ovarian and testicular tissue. This is rare. So please remember, male pseudohermaphroditism is 46XY. So the male and female doesn't refer to the phenotype, it refers to the karyotype. Okay, so male 46XY, but with feminization of the external genitalia, and female is 46XX, but with masculinization of the external genitalia. So they're usually born with ambiguous genitalia. And then later on, when on evaluation, you get to know what they are. Okay, so if you have time, read the book, Middlesex. It's a very nice book about 5-alpha reductase deficiency. Okay, a marker of ovarian reserve. Okay, this is also has been asked previously. So at first instance, the answer is anti-Mullerian hormone. I think most of you would have marked this. The other options were early luteal phase FSH, early luteal phase estradiol, early follicular phase estradiol. So later on, when I saw this question and I started thinking about it, this question, if the choices are correct, one other answer could have actually been early follicular phase estradiol, because a basal day 2 estradiol and a basal day 2 FSH are also markers of ovarian reserve, but I will still stick to AMH because AMH has a much better sensitivity specificity for ovarian testing ovarian reserve. Okay, if it was a multiple choice question also, then maybe you could have marked also early follicular phase estradiol. Luteal phase has no value of FSH or estradiol, but yes, basal day 2 estradiol, basal day 2 FSH are also used as markers of ovarian reserve. But I will repeat, the best option here was anti-Mullerian hormone. Okay, so as I said, what are the tests of ovarian reserve? Clinically, age. Age is one of the best measures. The younger the age, obviously, the better her ovarian reserve. A 20-year-old lady versus a 40-year-old lady, the ovarian reserve decreases with age. The menstrual cycle characteristics also give you an idea. If she's having prolonged delayed cycles, that means she may have a poor ovarian reserve. Biochemically, AMH, one of the best biochemical markers nowadays for ovarian reserve. Inhibin B is also used. Basal FSH, as I mentioned, and basal estradiol is around on day 2 to day 4 of the cycle. That is the early follicular phase. Other ways we can test for ovarian reserve: ultrasound, we do an AFC. What is an AFC? AFC is an antral follicle count. We also can see the ovarian blood flow and see whether blood flow is diminished or it is normal. That also gives us an idea of the ovarian reserve. What is antral follicle count? Is we count the number of follicles in both the ovaries on, again, this is on day 2 of the cycle. So we get a basal idea, and this is usually done prior to starting an IVF cycle. And dynamic tests are also there. The clomiphene citrate challenge test, which is not really done, but this just to complete the list of tests. This is an important table to remember. Next question. Okay, so this again was a little tricky, and I think many of you have marked it wrong. Okay, so a 24-year-old woman presents with infertility, hirsutism, and irregular cycles and is diagnosed to have PCOS. All will help in the management except. Okay, so what would you think the answer would be? Many of you have marked tamoxifen, but that is not the answer. The answer is oral contraceptive pills. Now you will ask me why. The answer is because tamoxifen is not commonly used, but in the West especially, in India it's not commonly used, but it is definitely a recommended treatment for ovulation induction in women with PCOS. What is the drug of choice for ovulation induction in PCOS? It is letrozole. That is, in PCOS, the drug of choice for ovulation induction is letrozole. What is letrozole? It's an aromatase inhibitor. The other drugs which we use are clomiphene citrate. So these two are the most commonly used. But tamoxifen also can be used. Tamoxifen is similar to clomiphene citrate. It is an anti-estrogen. It causes a negative feedback, reduces. So it is negative feedback, more FSH-LH is released, and that stimulates the follicles to form. Metformin is also used, and gonadotropins in resistant cases, we directly use FSH to cause follicular development. So letrozole, clomiphene citrate, tamoxifen, metformin, gonadotropins, and these are given in all your standard books. Tamoxifen is given. This is why I say don't rely completely on notes. Please go back and read the books for better understanding. Okay, and why OC pills? OC pills is used in PCOS. I'm not denying that OC pills are not used, but see the scenario that is given. The woman presents with infertility. You have to treat her, you have to manage her infertility. OC pills will regularize her cycles. Yes, so if the scenario was, say, a adolescent girl comes with irregular cycles and PCOS, hirsutism, acne, what will you do? then OC pills, yes, definitely an option, but not for a woman who is infertile and is wanting to conceive. We can give it for short duration, but amongst the options given, the best option would be OC pills, which is not used. Clomiphene is definitely used, tamoxifen is definitely used, and metformin is also definitely used, especially when we're dealing with infertility. So please remember this. Go back and read your books. Tamoxifen is given for ovulation induction. It is not commonly given, I agree, but it is definitely given for ovulation induction in polycystic ovarian syndrome. Okay, now the match the following. This is very easy. If you worked in the OPD, you can close your eyes and answer this. Commonly, we give kit 1, 2, 6, though, is like given to every other patient. So it's very common if you work in your gynae OPD. If you have not, now you try to understand. So kit 1 is for urethral discharge, kit 2 is vaginal discharge, kit 6, you should know this, kit 6 is PID. So even if you know 1 or 2, you can easily match the following. That's the beauty of these questions, that they are actually simple to do if you know at least 2 of them. Kit 3 is for non-herpetic genital ulcers. So quickly, briefly, we have 6 kits. We have 6 kits. Yeah, sorry, seven kits. Yeah, and sorry, my mistake. We have, so for kit 1 is for urethral discharge, kit 2 is for vaginal discharge, and you should know what they contain also. I won't go into the detail. This chart is available in most OPDs on the net everywhere. Kit 3 and kit 4 are for non-herpetic genital ulcers. One is with penicillin, the other one is for those allergic to penicillin. Kit 5 is for herpetic genital disease, and that contains acyclovir. Kit 6 is PID, okay, doxymetro combination. And kit 6 black is inguinal bubo. All right, so these are the kits, and you should know this. This has come repeatedly and is very, very important. Syndromic management of pelvic inflammatory disease. Okay, next question. A 32-year-old lady had 2 normal deliveries, presents with dull aching abdominal pain. Her LMP was 3 weeks ago. On examination, a cystic structure is palpated in the left fornix, which is revealed to be a clear left ovarian cyst on ultrasound. What is the best recommended management? Will we follow her up after 2 to 3 months? Will we do a CA125? Will we do a CT scan? Will we do a diagnostic laparoscopy? Again, there's a little controversy in this question, but let me explain. The answer is follow up after 2 to 3 months. Why? Because see the clues that are given. She's young. She's a 32-year-old lady. I'm not sure of her age, but definitely it was a young patient. Okay, she's not pregnant because LMP was 3 weeks ago. That is the relevance of that statement. Ultrasound shows a clear cystic lesion, which is 5 centimeter. So if we see, this is from the RCOG. Okay, if we see when we have an adnexal mass at the ultrasound, and if she's asymptomatic, so this lady had mild abdominal pain, and it is, and if the features are benign, simple, less than 5 centimeter, no further action is required. However, if the signs on the ultrasound are indeterminate or suspicious of cancer, so example, if it's a complex cyst, if it has septa, if she has bilateral cysts, if she has associated ascites, these are all markers that they may be malignancy, and then you go for tumor markers. Okay, it is not required to do so. Most of you have marked CA125, but young patient, simple clear cyst, mild abdominal pain, nothing needs to be done except wait. Now, similarly, this table is taken from Novak's, which is the standard book, which follows the American guidelines, and they say the same thing. Okay, so here they say less than 8 centimeters. If the ultrasound is cystic, just observe, or you can give suppression. What is suppression? We can give oral contraceptive pills to suppress the cyst, because these cysts are usually follicular cysts, all right, and they respond well to oral contraceptive pills. Okay, but however, if it is complex, solid, and suspicious, then you go for surgery. So remember, a cyst usually less than 6 centimeters we see, or less than 5 centimeters, especially as per the RCOG. And if it's simple and cystic, nothing needs to be done. If the ultrasound is benign, we don't even need to do a CA125. The question, please remember, what is the best recommended management? And hence I took out the recommendations. This word was mentioned in the question, what is the best recommended management? So the best recommended management is do nothing, follow her up after 2 to 3 months, because the chances of complications or this being malignant is very, very less. Okay. Next question, easy question. In a normal sperm analysis, what should be the least percentage of morphologically normal sperm? And the answer is 4%. You should know this table, very, very important. Normal sperm volume 1.5 ml. This is the WHO 2010 values. This is the most recent one. Sperm concentration more than 15 million per ml. Total sperm count 39 million. Sperm progressive motility 32%. Sperm morphology, this is the least of 4%, and the others are not that important. So you should know what is azoospermia, no sperm seen in the ejaculate, oligospermia, less than 15 million, actinospermia, less than 32% progressive motile sperm, and teratozoospermia, less than 4% morphologically normal sperm. So you can get a question in terms of these definitions, or they can directly ask you the values. So this is again from infertility. This is a very, very important topic, male infertility. Usually a question does come on semen analysis. Okay, so another tricky question. Okay, so I think many of you have not got this correct. Lactating women need more of what compared to pregnant women? Most of you have marked calcium, but that is incorrect. I'm sorry to say. The correct answer is vitamin A. Okay, so you would think lactating women produce milk, so calcium is required. I understand that association, but that is wrong. Calcium requirement remains the same as a pregnant woman, that is 1000 milligrams. So if we see this table, vitamin A requirement increases, almost doubles in lactation. Okay, so from 770, the requirement becomes 1300. This is the RDA, recommended daily allowance. Folate levels remain more or less the same. Calcium remains the same. Iron requirement actually decreases in lactation. All right. So important. This is it's a tricky question. I understand most of you would not have known this, but please remember now onwards that vitamin A levels increase. Sorry, vitamin A requirement increases in lactation. All right. Again, easy question, which complication is specific to monochorionic twins? And the answer is twin-to-twin transfusion syndrome. If we look at this diagram, this is just basically what is the basic difference between a dizygotic twin and a monozygotic twin. So dizygotic twins are basically two sperms fertilizing two separate ova. Monozygotic twins are basically one sperm fertilizing one ova, and then depending on when that the zygote splits, different twins are formed. So dizygotic are always dichorionic, diamniotic. They have their separate amniotic cavity. They have their separate placenta. Monozygotic, if the splitting occurs early, they become diamniotic, dichorionic. If the splitting occurs a little late, what happens? The placenta is already formed. So they are monochorionic, but two separate amniotic cavities. So they are monochorionic. Single placenta, chorion refers to placenta, and diamniotic, two separate amniotic sacs. Monochorionic, monoamniotic is when the splitting occurs even later, after the 8th day. The chorion has formed, the placenta has formed, the amniotic cavity has formed, only the fetal pole split. So this is called a monochorionic, monoamniotic. And if the splitting occurs very, very late, after the 14th day, we have conjoined twins. So this diagram is very, very important. Lots of questions come on this, and this is very important because monochorionic. So this and this, although rare, monochorionic twins are more susceptible to complications, especially vascular related complications, because they share a common placenta. So they have a lot of arteriovenous anastomosis, and that ends up leading to complications. The two classic complications we should know are twin-to-twin transfusion syndrome and twin reversed arterial perfusion or trap sequence. So TTTS and the trap sequence. And if we go back, discordant twins are seen in both diamniotic, dichorionic, and monochorionic. Okay, there are different reasons. Space is less. Mainly the reason is constraint of space in the uterus. So there is some amount of discordancy. Preterm labor is seen in all multiple pregnancy. Fetal growth restriction is similar to discordancy. Is seen in all. Okay, so TTTS and trap sequence are specific to monochorionic twins. So multiple pregnancy is another favorite from the MCQ point of view, because you have a lot of rare things, and somehow the examiners like asking rare things. Okay, another question, which is, this is again simple, straightforward, although some of you have again been confused with this. from the discussions we've had, which is not a component of the active management of third stage of labor? Is it controlled contraction? Is it early cord clamping? Is it uterine massage? And is it uterotonic? So answer is early cord clamping. Many of you have thought that uterine massage also, because the latest WHO guidelines now says that massage is not required. But if you read carefully, if you read the document carefully, it says massage can be given, especially in women who have not received oxytocin. Another sort of confusing thing which was given here was uterotonics after delivery of the placenta, whereas the WHO document says after delivery of the baby. So many of you have thought that this also could be wrong. But if you see and try to analyze the question, the best possible answer I feel is early cord clamping, because very clearly WHO says cord clamping should be delayed. Uterine massage, it doesn't mention much, agreed, but it says it should be done in case the uterus is flabby and in case oxytocins have not been given, and uterotonics have to be given. Agreed, after delivery of the baby is when it should be ideally given. But amongst all the options, early cord clamping seems to be the best possible answer. So what is AMTSL? Initially, it was started by FIGO and the International Confederation of Midwives, and they said AMTSL consists of interventions designed to facilitate the delivery of placenta by increasing the contractions and to prevent PPH by averting uterine atony. And the components initially, the initial components were administration of uterotonic agents, controlled contraction, and uterine massage after delivery as appropriate. But this has changed over the years, and recently WHO 2012 gave a refocused approach. What did they say? Uterotonic immediately after delivery of the baby. And what uterotonic is the best one? Oxytocin 10 units intramuscular is the preferred drug to prevent PPH. Then they said delayed cord clamping to prevent fetal anemia, 1 to 3 minutes after birth to prevent fetal anemia. Then they said CCT, if required, perform controlled contraction. And then they said postpartum vigilance. Now, in this vigilance, if you read carefully, what does it say? It says immediately assess the uterine tone to ensure a contracted uterus and continue to check every 15 minutes for 2 hours. If there is uterine atony, perform fundal massage and monitor more frequently. So it, and also it mentions the cold chain should be maintained for oxytocin supply. So please remember this. Uterine massage is a component of AMTSL. Don't think it's not, okay? But it is used only in those women who, especially who have not received oxytocin for some reason, and in those women who on continuous checking, you find that the uterus is flabby, okay? So it is a part. So when you read a document, don't just read, especially in your first reading, give it a detailed reading and then make your notes. Don't just go by the headings. Try to have your first reading should always be the best reading. You should always try to understand the concept instead of just immediately trying to mug it up. Okay. So again, as I said, the answer, most appropriate answer here would then be early cord clamping, because cord clamping should definitely be delayed. The others still make sense. Early cord clamping is to be delayed. So AMTSL is a very, very favorite question again asked, and many of you get confused because of the various revisions, but please remember the premise remains the same. Okay, so massage is definitely a component, although it may not be an immediate component, but it should be done if the uterus remains flabby. Preeclampsia pe to question आना ही है, it has to come. Preeclampsia, and the very, very easy question came. So what was the question? 36 weeks patient, blood pressure 150 by 105, dipstick of 3 plus, and then you inquire about symptoms of imminent eclampsia. So what are those symptoms? We all know blurring of vision, headache, epigastric pain, and vomiting also is a feature of imminent eclampsia. What is not? Persistent pedal edema can be seen physiologically also. It can be seen as in preeclampsia also, mild preeclampsia also. It is not a feature of imminent eclampsia. So this is the correct answer, and I don't think I need further explanation. Preeclampsia, eclampsia should be on your fingertips. Question has to come from here. Okay, the features seen in the karyotype below. So there was a karyotype given, and then it was asked you what are the features in a patient with this karyotype. So what do we see? First, we have to analyze the karyotype. We can see there are 2 X chromosomes and one Y chromosome. So this is 46 XXY, which is Klinefelter syndrome. And what are the features of Klinefelter syndrome? This is again, I think, an easy question. Long, thin limbs and gynecomastia. So these are the features of Klinefelter syndrome. So taller than average height, reduced facial hair, reduced body hair, gynecomastia, feminine fat distribution, osteoporosis, testicular atrophy, and varicose veins. So these are features of Klinefelter syndrome. Again, easy question. There was an image and it was asked, what is this image? I think it was the exact same image, if I'm not mistaken. Um, uh, the choices were fibroid polyp, uterocervical prolapse, inversion of uterus, and cervical polyp. So the answer was, obviously, this is a prolapse. Why do I say obviously? Because you can see the cervix here. So whenever you can see the cervix, it becomes a uterocervical. This is a 3rd degree or a 4th degree prolapse. We can't differentiate till we palpate her. But this is not a fibroid polyp or a cervical polyp or a uterine inversion because we can see the cervix. So uterine inversion, you will find it is very red in color and it has a velvety sort of appearance. The uterus is completely turned inside out. Okay, and it is again rare, but if at all, if you see the cervix, please remember it is a prolapse. It's a uterine prolapse. Okay, this was another question. Okay, so I didn't get the exact image, but I've seen the image and uh, so it was basically a swelling and it was on the opposite side, I think, from the image that I've shown, it was a vulval swelling. And the answer was a vulval hematoma. Please remember that was a classic picture of a vulval hematoma. And it didn't seem to be post-delivery. It was probably following a perineal trauma, but that was a vulval hematoma. It did not have a grade. It did not have the proper bluish a tinge of over the skin, but that's not necessary. If the bleeder is deeper inside and if the blood collection is deeper inside, you may not see that typical bluish hue. Although if you see that bluish hue, it gives a better diagnosis. Why is it not vulval carcinoma? Because vulval carcinoma appears like a ulcerative malignant growth which bleeds on touch. So that's how something like a vulval cancer will appear. Condyloma lata are basically verrucous cauliflower plaques, secondary syphilis. Condyloma lata is in secondary syphilis, so that will look something entirely different. Many of you wrote Bartholin's. So Bartholin's basically is seen when you separate the labia majora. It is seen in the lower part because the Bartholin's glands are found in the lower portion of the labia at the base of the labia minora. And that's how a Bartholin's cyst will see. It will be very, very well circumscribed. It will be very well defined circular, not like what was shown. What was shown was an irregular, large, one-sided unilateral swelling, and that was a vulval hematoma. So a Bartholin's cyst is very, very well defined, circular, and limited to the lower lateral junction between the labia majora and the labia minora. So that was a vulval hematoma. Again, a little confusing question. All are components of quadruple marker except, was it HCG? Was it unconjugated estriol? Was it alpha fetoprotein or inhibin B? So those of you who have read in detail, it should have struck you immediately. Inhibin B is not used, inhibin A is used as a component of quadruple marker. And that is why this question has come previously also in AIMS, and that time they changed. I think that time it was not E3, it was E1 or something like that was given in the one of the previous AIMS papers. So they like making these subtle changes just to confuse you. But if you've read thoroughly, you would know that inhibin B is the answer. So what is the triple test and the quadruple test? They are basically tests for Down syndrome screening. Triple test, the components are beta HCG, unconjugated estriol, and maternal serum alpha fetoprotein. If we add inhibin A to the mix, it becomes a quadruple test. Okay, and what happens in Down syndrome? What are the values? This also is very important. Beta HCG and inhibin A are increased and AFP and estriol are decreased. How do I remember that? Big B for big, or so basically wherever there is B, so beta HCG and inhibin, these two have B in them, and that is big. Big means increased, and hence beta HCG and inhibin A are increased in trisomy 21. Easy way to remember. That's how I remember. You can find your own ways to remember, but this is a very important part. So usually Down syndrome screening, one question has to come. It's very, very important for both NEET PG and your INICET. Okay, again, a question which some of you did get confused, but it's actually a very simple question. A 21-year-old gravida 2 presents at 20 weeks. She has brought her ultrasound films which show the following and seeks your opinion. What is your diagnosis? Is it an omphalocele? Is it an anencephaly? Is it an encephalocele? Or is it a cystic hygroma? So this is a sagittal view of the fetus. And most of you would have read anencephaly seeing the frontal view. The frontal view has the typical frog face appearance and hence the reason for confusion. If you can see here, there is absence of the cranial vault. Okay. and the cranial vault would have appeared much more, and you would have seen the skull bone much more clearly at 20 weeks. So this is absence of the cranial bone. So even if you didn't know, it was obviously not an omphalocele because there is no protrusion from the abdominal side. There's no encephalocele because there's no protrusion or herniation of brain matter seen here. And it's not a cystic hygroma because there's no neck swelling. So it is, even if you use method of exclusion, this becomes an anencephaly. Anencephaly is very important. It's very commonly asked, okay, because it's one of the few things which as an undergraduate you are expected to know, to be able to identify. So this is the picture which is usually shown in ultrasound picture. This is called a frog face appearance, absence of the cranial vault. You can see the two orbits and no cranial vault, and this gives the appearance of a frog face. So this, it can importance of anencephaly is one of the anomalies, few anomalies which can be diagnosed in the first trimester scan between 11 to 14 weeks. Apart from all these other ones also, it can be diagnosed between 11 to 14 weeks. And this is the picture which was given. Sagittal view, it will appear like this. Okay. This is an encephalocele. You can see the cranium. This is the skull bone. So in ultrasound, anything white is bone. Very, very white is bone, and black is fluid. So the black is the liquor, amniotic fluid, which you can see here, and this is the skull bone. Okay, and you can see this herniated matter. This is a encephalocele. This is an omphalocele. See, you can see the herniated abdominal contents coming out from the abdominal cavity. This is an omphalocele. And you can see this is a cystic hygroma. This is the fetal head. This is the neck region. So cystic hygroma is a swelling in the neck region. So you can see this swelling. Black is fluid, so it's full of fluid. And this is how a cystic hygroma will appear. So it's important to know how the other images will also appear. So when you're reading for your exam, don't just concentrate on what has been asked. Concentrate on what the other options may also look like, especially in image-based questions. Okay, so another little tricky question. True about human transplacental CMV infection is, and the options were, the classic triad of hearing loss, hypoplastic enamel, and intracranial calcification is seen in 30 to 40% of symptomatic babies. Hearing loss can appear later in life in asymptomatic babies. 30 to 40% of babies with CMV infection are symptomatic at birth, and babies born to mothers who have IgG CMV antibodies are immune to transplacental spread. And the correct answer is hearing loss can appear later in life. Now, a little bit about CMV infection in fetuses. So 90% of babies are asymptomatic at birth, and the most common clinical triad what I could find is jaundice, petechia, and hepatosplenomegaly. Okay, so the triad that was given was, I couldn't actually find that triad, but even so, it is, most of the babies are asymptomatic at birth. 30 to 40% is quite a high number. Okay, most are asymptomatic at birth. So the correct answer was, and develop late onset sequelae, including hearing loss. This is correct. And despite women having IgG anti-HCV antibodies, what happens in CMV is the virus becomes latent, like most viruses, and they have periodic viral shedding. So fetal infection, transplacental spread can still occur despite having a high level of IgG anti-HCV antibodies. Okay, so we're almost nearing the end. Which is an unusual cause of secondary amenorrhea? Was it Kallmann syndrome? Was it Turner mosaic? Was it fragile X or Sheehan? The answer is Kallmann. So Kallmann syndrome basically presents with primary amenorrhea, whereas the others, Turner mosaic, Turner's presents with primary, but Turner mosaic presents with secondary. Fragile X presents with premature ovarian failure and hence secondary amenorrhea. Sheehan syndrome, we all know, following PPH. So again, secondary amenorrhea. Kallmann's is primary amenorrhea. So amenorrhea again is a very commonly asked area. Lots of questions from there. So characteristically, they have hypogonadotrophic hypogonadism and anosmia. Okay, so primary amenorrhea with anosmia is Kallmann's syndrome. Important to remember. Okay, and the last question I have put here, because it is although anatomy, but it has a lot of relevance in obstetrics also. The question was, branches of the anterior division of the internal iliac artery include the superior vesicle, the inferior vesicle, the middle vesicle, superior gluteal, inferior gluteal, and vaginal. So I think these were the options given. And the answer was, these are the branches of the anterior division of the internal iliac artery. So how do we remember this? Always try to make mnemonics. It makes life much easier. So this is the mnemonic I have made, Mr. Vigip Ozio views. So what is Mr.? MR is middle rectal. The vesicle, both superior and inferior vesical arteries are branches of the anterior division of the internal iliac artery. IG is inferior luteal. IP is internal pudendal. O is obturator. U is uterine. And V is vaginal artery. So these are the branches of the anterior division of the internal iliac. And why is it so important? Internal iliac artery is very important obstetrics because it is part of devascularization, especially in refractory postpartum hemorrhage. If you do an internal iliac artery ligation, it will reduce the pulse pressure by 85%, and it is used as one of the last resort measures in refractory postpartum hemorrhage. And another commonly asked question is, where do we do the ligation? We do it 5 centimeters distal to the common iliac artery bifurcation. Why? To avoid posterior division branches. So we have to ligate the anterior division because that is where the uterine artery is coming from, and we have to ligate it 5 centimeter distal to the common iliac artery bifurcation. So this is another important point. So this ends our discussion on 29 questions in Obs and Gynae. Please leave a message in the chat box if you enjoyed the discussion, and if you want any further clarifications, please let me know. To end, a famous quote by Atul Gawande, who's a very famous surgeon and a writer. Better is possible. It does not take genius. It takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. I wish all of you the very best of luck for the result and for your further exams. Thank you very much.